Welcome to our fourth video on diseases of the esophagus. Let's begin. In this lecture, we'll discuss esophageal perforation and infectious esophagitis due to herpes simplex virus, cytomegalovirus, and candida. We'll discuss definition, risk factors, pathophysiology, clinical presentation, diagnosis, and management of esophageal perforation. Esophageal perforation is the transmural esophageal wall rupture. In other words, all layers of the esophageal wall are torn and there is communication between esophageal lumen and mediastinum. This is in contrast to Mallory-Weiss syndrome, which results in only mucosal lacerations at the gastroesophageal junction. Boerhaave syndrome is a special type of esophageal perforation characterized by distal transmural rupture due to forceful vomiting. The most common risk factor for esophageal perforation is esophageal instrumentation, such as endoscopy. It can also be caused by foreign body ingestion, blunt or penetrating chest trauma, and esophageal cancer. Esophageal cancer growing within the wall disrupts its integrity and leads to perforation. Forceful vomiting can also predispose to esophageal rupture. Let's talk about how these conditions result in esophageal rupture. An irritant stimulus increases the intraluminal esophageal pressure. Excessive increase in the intraluminal pressure then causes a transmural esophageal rupture. Esophageal perforation is characterized by severe chest pain and hemodynamic instability, manifested by hypertension and tachycardia. Direct communication between esophageal lumen and mediastinum causes the esophageal air to escape into the mediastinum. This will result in pneumomediastinum. Pneumomediastinum is evidenced by subcutaneous emphysema on palpation of the neck and manubrial notch. Hammond sign is also suggestive of pneumomediastinum. Hammond sign is the crunching sound during heart auscultation that is synchronous with the heartbeats. It's caused by accumulation of air around the pericardial cavity. Esophageal perforation is diagnosed by gastrographin studies. Gastrographin is a water-soluble substance, which is why it does not irritate the mediastinum. Gastrographin swallow will also show the leakage of gastrographin from the esophagus to the mediastinum. Barium studies are avoided in the setting of suspected esophageal perforation because mediastinal leakage of barium can cause acute mediastinitis. Chest X-ray or chest CT scan will show loosened areas around the bronchi and the heart consistent with air in the mediastinum. It's worth mentioning that endoscopy is avoided in these patients to prevent exacerbation of esophageal perforation. Here we have the gastrographin studies in a patient with esophageal perforation. We can appreciate leakage of gastrographin from the esophagus into the mediastinum. This is a chest X-ray showing pneumomediastinum. Please note these loosened areas consistent with mediastinal air. Management of esophageal perforation includes IV fluid resuscitation, IV proton pump inhibitors, and emergent surgical closure of esophageal wall tear. A 48-year-old woman presents to the emergency department with severe retrosternal chest pain for the last hour. She's alcoholic and she has vomited 6 times before her pain started. ECG is normal and test results of serum troponins are negative. Gastrographin studies show leakage of gastrographin from the esophagus to the mediastinum. What is the optimal management of this patient's condition? This patient presents with severe retrosternal chest pain, normal ECG, and negative test results of serum troponins. She's alcoholic and she's vomited 6 times before her pain started. Gastrographin studies show leakage of gastrographin from the esophagus to the mediastinum. These findings are consistent with the diagnosis of Boerhaave syndrome. The optimal management of Boerhaave syndrome includes IV fluids, IV proton pump inhibitors, and emergent surgical closure of perforated esophagus. Let's move on to infectious esophagitis. In this section, we'll talk about esophagitis caused by herpes simplex virus, cytomegalovirus, and candida. We'll address definition, risk factors, pathophysiology, clinical presentation, diagnosis, and management of infectious esophagitis. Infectious esophagitis, as the name implies, is an infection of esophageal mucosa. It's commonly caused by herpes simplex virus, cytomegalovirus, or candida. Infectious esophagitis is rare in immunocompetent patients. In fact, the main risk factor is immunosuppression. Immunosuppression can be caused by HIV infection, organ transplantation followed by immunosuppressant intake, or chronic glucocorticoid use. Immunosuppression allows viral or fungal invasion of esophageal mucosa. This will induce lymphocyte infiltration in the esophageal wall, which in turn will cause mucosal inflammation. Infectious esophagitis commonly presents with fever, dysphagia, and odynophagia, which is painful swallowing. Let's talk about diagnosis of herpes simplex virus esophagitis. Endoscopy will reveal punched-out ulcers suggesting esophagitis, specifically due to herpes simplex virus. Light microscopy will show multinucleated giant cells with eosinophilic intranuclear Cowdrey A inclusions. Here we see the endoscopic findings of HSV esophagitis. Please note these punched-out circular ulcers with whitish yellow exudate. Here we see the biopsy image of the HSV esophagitis. We can appreciate these multinucleated giant cells and intranuclear eosinophilic Cowdrey type A inclusions. Let's move on to endoscopic and biopsy findings of cytomegalovirus esophagitis. Endoscopy shows linear rather than circular esophageal ulcers. Light microscopy, on the other hand, will show intranuclear Owl's eye inclusion. Here we see the biopsy image showing these intranuclear owl eye inclusions. Finally, let's talk about findings of Candida esophagitis. Endoscopy will show irregular white plaques similar to those of oral thrush in case of Candida esophagitis. Light microscopy will reveal yeasts and pseudohyphae. This is how Candida esophagitis looks like on endoscopy. We can appreciate these irregular white plaques on the esophageal walls. Here we see the light microscopy image of the Candida esophagitis. Please note the pseudohyphae. Let's move on to the management of infectious esophagitis. HSV esophagitis is treated with acyclovir. CMV esophagitis, on the other hand, is treated with ganciclovir. Ganciclovir-resistant cases can be managed with foscarnet or cidofovir. Finally, Candida esophagitis is treated with nystatin or fluconazole. A 38-year-old woman presents to the office with painful swallowing and low-grade fever. She's had HIV infection for the last 10 years. Endoscopy reveals linear esophageal ulcers. What's the best initial treatment option for this patient's condition? This patient with long-term history of HIV infection presents with painful swallowing, also known as odynophagia, and low-grade fever. Endoscopy reveals linear esophageal ulcers. These findings are consistent with the diagnosis of esophagitis due to cytomegalovirus infection. The best initial treatment option for cytomegalovirus infection is ganciclovir, and that concludes this section.